So it is with great pleasure that I am going to introduce now our guest speaker, Dr. Lourenco Camnahas. It was an amazing coincidence that resulted in me inviting Lourenco to come and talk to us today. I first met Lourenco 21 years ago as he applied to rent the flat attached to my house, which is close to Flinders University, where he had a scholarship to study health administration. I'm pretty small. As I get older, I get even smaller. Soon afterwards, his lovely wife Nancy arrived with their new baby, Eugenia. And Eugenia's here today, just having celebrated her 21st birthday. After 3 years, he returned home to Timor-Leste to work in healthcare administration, but later came back to Flinders for further study with new daughter Gabriella, who also is here and has also just had a birthday, and she has turned 16. Finally, a few years ago, Lourenco came back yet again with his family and completed his PhD. But his return home was marred with great tragedy, as before they left, during a short holiday in Melbourne, Nancy suddenly died. I've kept in contact with Lourenco and his family for over 21 years. They are really lovely and impressive people, and I'm so lucky that they call me Nanny Monica. So when I heard that Wendy More's work as coordinator for the clinical and leadership program at the St. John of God International Health Centre in Dili, I mentioned that I had a friend in health administration in Dili and found to my amazement that Lourenco had just been appointed as country manager on their nursing development program aimed at improving patient care across Timor-Leste. Wendy More was to be here today as well. I'm not sure where she is. As Dr. Camnahas Bios says, he has knowledge and skills in administrative systems in government, non-governmental organisations, UNICEF, World Bank, Asian Development Bank, and has been an independent researcher in areas of public health, healthcare, financing, public finance management, supply chain management, and institutional development, and is a member of the Academic and Research Council for Timorese Catholic University, plus a member of the National Agency for Academic Accreditation in Timor-Leste. So he is super well qualified to talk to us today on the health programs he is involved with in Timor-Leste. Please come. And I will see if I can are you any good at pressing that? That's your presentation. Yeah. And okay. Right.
I would like to begin by thanking, I call Monica, Nani Monica, as my daughters call her that way. We all call her Nani Monica. But I would like to, before beginning my presentation, I would like to say it is a privilege. Making contact with Rotary Club today is not the first thing I do, but this is the second time when I've made my contact, get some support from Rotary Club. I'd like to thank you and the Rotary Club from Melbourne, who has been working with me when we're setting up the National Institute of Health, Health Sciences Timor-Leste. Now it's up and running. It's providing services to the whole country. We use the old way in Timor-Leste. I would like to, again, pay my respect to the president of Adelaide Rotary Club, commissioner, past president of Rotary Club, Director Monica, other directors, members of the Rotary Club Adelaide, distinguished guests, ladies and gentlemen. My presentation today will only focus on two things. One, the challenge in public health services in Timor-Leste, and the second part will be the work that St. John of God is doing in Timor-Leste to support the country, especially in health sector. So I'll begin my presentation. 15 minutes, I'll try to cover everything, but I'll just chop through whatever I can, just to deliver what I can. So in Timor-Leste, as we see, for those who have not been in there, it's a half-island country where we have 12 municipalities, if you look at this, and one autonomous region at the west, West Timor. West Timor belongs to Indonesia, so it's half-island, and we are at the enclave. And I'm from this area at the west, very close to Indonesian, one of the Indonesian provinces there. And the health system in Timor-Leste is built around the structure, as you see. We have one autonomous region, 12 municipalities, 69 sub-districts, and 442 villages in the country. And our system is built based on that. So we have this, at the ministry, we have the central services of the Ministry of Health. Well, it houses all the general directors, national directors, and head of department oversee policy development for the health sector. But we have 5 autonomous agencies attached to Ministry of Health. There is a national laboratory, we have central medical store, national agency for ambulance services, national health institute, as well as a national hospital. We have 12 municipality health services, which oversee the primary healthcare service to the population in all 12 municipalities. We have 6 hospitals, 1 national hospitals of 230 beds, and 5 regional hospitals, 120 beds each. And in each municipal health services, there are 71 community health centers. That's one level down, it's a sub-district level, where the service is more on health promotions, outreach services, vaccinations, and screening for pregnant mothers at that level. And then we have 42 maternity houses where our people go for deliveries with support from midwives and doctors. And the lowest upfront health service is the 313 health posts in the country. That's all we have in the country. And with that, we up and run with the service we offer to the people in the country. In the past 20 years, we have noted changes in our achievements. The noted one is about maternal mortality rate. When we started in 1999 and even 2002, there were 800 deaths, MMR, maternal mortality rate, among 100,000 people. 20 years later, we have pushed that down to 142 deaths of mothers among 100,000 people in the country. I helped set up the vaccination program for the country. When we started, the polio 3, which is the coverage, as well as DTP, diphtheria, pertussis, tetanus, were only 32%. Now we're able to get into 85% of the kids vaccinated. So with that, it doesn't tell anything that we are success. There are always challenges there, and I have a few factors, challenges that I presented to you. That ranges from hygiene and sanitation. We still struggle with clean water, the effort to provide clean water to our population. We still struggle with sanitation within the communities. Ministry, the government has put some efforts with partners like NGOs, UN agencies, but it's a long way to go, and that's one thing that we struggle with. Another thing next to that is some epidemiological factors. I mentioned dengue. We successfully almost get rid of malaria in the country, but not dengue. Our malaria cases are down to almost 0 cases per year, supposed to be declared as a country free of malaria, but not dengue. 10 years ago, we have an outbreak, and we think we can rid of dengue, but it's not the case. Between January and May this year, apart from having COVID outbreak, we did have a dengue outbreak, where the hospital is full with dengue cases of up to more than 2,800 cases. So that's another epidemiological factors, but we're also seeing increase of non-infectious disease. We've seen HIV/AIDS increasing, while we are still dealing with tuberculosis as well, one of the diseases that we're still dealing with. So there are other factors coming up. And then environmental factors. The climate change, where the heat, I have experienced that, I haven't seen that increase in temperature also contribute to malaria. It will stay as the temperature rise. So that's one thing, but also knowledge things of people seeing health and how they do some exercise. That's other factors towards non-infectious disease. The next one is disease preventions. It's related to how educated our population is and how we can make our promotions to prevent preventable disease. One of clear thing is through vaccination for kids, but also in other matters. And the next one is policy and regulation. I almost work in the health system since Indonesian, as well as 20 years after independence. We still struggle with our policy and regulation in the health sector, where most people will work in silo. We'd like to connect it. We have policies and regulations that make everybody work together, government, partners, NGOs to work together, but also policies in public service system, where public servants may be well placed not to be in politics. In Timor, it's not the case. Every public servant is a member of a political party. And the challenge is, when appointing directors and head of departments, it's not based on merits. It's based on political connections or affiliations. And a director can only last for 6 months because his party lost, or there's a motion of no confidence in the party, means the directors and the head of the department has to go. This affected how we work. What did I do? How we work and how, as NGOs, I've worked with other partners, see how can we struggle. So every time a new director is appointed, meaning we start from beginning again, explaining, getting your programs up and running. And before you even implement the program, that director is replaced next month. So there's one thing, one example of that, what I mean by other policy and regulation issues in our system. And another list of 3 when it's related to poverty. I myself conducted the first survey for Social Protection Index in Timor-Leste for the first time. We haven't gone far enough. In 2012, the poverty index was 42% out of 1,300,000 population in Timor-Leste. It hasn't gone down so much, 40% as of last year. I haven't published the second research. It hasn't gone much down there. So we still have that, almost 50% of the population still live under poverty line. And with that comes many issues. When you are poor, there are devil cycles in there. You're not educated, nutrition is an issue, and so on. And it becomes a challenge, another challenge in public health in our country. Infrastructure. We've seen major development in road constructions and basic infrastructures for general public, as well as in the socially as well as in the health sector. Road connections are good, but maintenance of these infrastructures remains an issue, including maintenance for health facilities. That's hospitals, that community health centers and health posts. The procurement system and people's willingness to get themselves into the regulations or procurement regulations is an issue. So it's there, maintenance is an issue, and it poses a challenge, remains the main challenge to us. Human capabilities is one thing that remains a challenge in skills developments, capacities, and confidence to manage programs. Under Indonesian occupations, we all were technical implementers. Only a handful of people involved in policy development, regulations, guidelines. They're not thinkers, they're implementers. We learn to be thinkers, we learn to be regulators, and that becomes an issue for us to manage independently. With support from partners, UN agencies, NGOs, we moving, but it's a long way to go. And building human capability is one work that St. John of God is doing in Timor-Leste, and I'll go through what does it mean. Politics, it links to policy and regulations I've explained before, so I will not go in depth on that. But basically, you win the elections, you rule. You lose today, you get out from your positions. You go on holiday like today, I'm coming here. When I return, I have no chair. So that's what happens in Timor-Leste. I think that's main challenge and factors affecting how we try to deliver and how the health service, especially primary healthcare and public health, are facing in Timor-Leste. And I'll move to my second part, which is the work of St. John of God in relation to human capacity development. So, I may have an introduction. St. John of God in Timor-Leste has worked with the country since our restoration of independence in 2002. And when it started with pathology services. I have 5 minutes to go, thank you. But down the lane, in 2016, ministry requested that it change its direction, leaving pathology services and provide capacity building on a program called Nursing Development Program. And in the program, we have these 3 areas: clinical governance and leadership, education and development, and quality assurance. In education and development, there are 3 main programs which we do at the National Hospital at the moment. We focus on improving clinical core competencies of nurses and midwives and training of trainers of nurses for sustainability of our programs, as well as we see there's a new nurse and midwifery program, induction for new nurses to get them ready, workforce ready. So these are the 3 areas we do. And in clinical leadership and governance, which we have our coordinator here, Senora, we call Senora, is like Madam Wendy Morris with us, running 2 models. One, health managers program, targeting nurses and midwives, but also some specialist services that links with any disease, rheumatic heart disease, and other needs as it arises in obstetric and gynecology, pediatric, surgical, and all areas we need. I just want to draw your attention on the health managers program, the first one. It's a model that everybody likes it. We do it for nurses and midwives, doctors likes it. So the target is not only nurses and midwives, doctors are there. General directors are in Madam Wendy's course. And since 2016, we now have 79 graduates out of 103 trainees. They come with 73 quality improvement projects in their workplace. It's a good program with typical and features, coaching, dynamics, and responding to the needs of ministry. And with that, that's the one that triggered us to look for support, for further support in this program. And then the last one is quality assurance. We're doing that by looking at improving standards in hospitals as well as hospital-wide survey for accreditations. And for the standard accreditation has been 3 times with some improvement. In 2012, there were only 4% out of 8 target areas improvement, but in 2019, it increases to some improvement to 32%. There's some improvement. But in this year, Minister asked us, let's get together and get our understanding of what does it mean by saying accreditation and standards. We ended up having a national seminars, and there's one project also coming up for IPC. IPC is one of 8 components in hospital accreditations. We are going to start with that in the next 3 years as a pilot project. And that's my last slide. So what is next? That's from 2016 to 2000, for today, in June. So fiscal year, this year ended in June. And what we're going to do next 3 years are 4 commitments. We'll continue to advocate for nursing professional standing in the ministry by having a highest position. We have successfully done that in the past in my other positions, and we'll continue to do that by having a chief nursing officer, and that will follow with medical, midwifery, and others. But we're going to start first. The second commitment is to support ministry through management, leadership, and executive programs. That is one of the health program manager training as well, but also executive program by twinning or coaching by twinning executives in Australia with our executive in Ministry of Health. And the third commitment is supporting implementation of hospital accreditation standards. I mentioned how we mean by that. The last one, but important, is supporting development of clinical knowledge and skills for nurses, midwives, and doctors to confidently manage clinical or administration in the country. And we'll continue to do that. I think that's the commitment for the next 3 years. And with that, that's my last slide. I will be happy to take questions. Thank you very much for your attention.
Lots of countries give a lot of aid to Timor-Leste. So, how is the aid being managed? When you say political, there's no continuity and politicians change regularly.
Yeah.
How is all that aid being managed, and is it achieving the purpose of what it is being given for all the foreign aid?
Thank you very much. It's a very good question. I will give one example. So how the aid being managed. I've worked with the DFAT program through the World Bank as well as other program. So the aid is managed through certain stages. From 2002 to 2008, when we have CC program, that program is managed and funded by DFAT as well as European Commission. It's managed through a trust fund administered by the World Bank. So ministry, for example, health sector, receive the product of that. So it has programs, well consulted to Ministry of Health, but managed by a third person, a third party. In between 2009 and 2012, there was a move to have direct funding within the government. Some donors agreed to do that, but there's a weakness in managing donor funding. Corruption still remains things that we don't want to take the risk. So there was a halfway through where the donors like DFAT, EU, Ireland Aid, and JICA and COICA, Korean, struck to an agreement. Let's do a PMU, Project Management Unit, when it's managed by ministry, but still with the steering committee from all the donors. That is still the 2 approaches used so far. Nowadays, European Union, for example, funding the nutrition program with direct funding within the Ministry of Health. But that's the only donor that started to do that with direct funding within the government state budget. I hope, Mr. President, that can answer your question.
I
Yes, I'm from there, but I have not been there in the past 14 years in my own little area. That enclave area is an autonomous region. It runs like another government. So to get there, there is a president of authority who manages everything, still connected to the central services. It's a small area of, a district consists of 4 sub-districts. It's 20 by 60 kilometers in length. So when you mention about those remote areas, our concept is to build, for example, health posts, the upfront health services to the population of 1,500 people, communities with 1 health post. But that's the concept. In practice, other communities only consist of 500 people, and it's difficult to provide them with nurses, doctors. That health post consists of a doctor, a nurse, a pharmacist, and a lab technician. In practice, it's difficult still to do that. How we reach the population in need? There is a monthly outreach services called SISCA, and I'm one of the person managing that and established that. It's up and running. It provides health promotions, but also clinical services with certain level to vaccinations, antenatal care for mothers, and postnatal care for mothers as well, but also some health promotions. So we don't reach them through all health facilities, but they are out services that we do.
Are your nurses able to use the same language across Timor-Leste, or do they have to vary from village to village?
It's another good question. Most of us, like me, I don't speak a lot of Portuguese, but our official language is Portuguese. And with that, Tetun is also come as another official language, and English and Indonesian language as working languages. But we have at least 16 dialects in the country. And luckily we all speak Tetun, like me. I learned Tetun when I came to Dili in 1986. In our area at the west, we speak Baikenu. It's a language is not spoken in other 12 municipalities. We have Tetun. So nurses and doctors, midwives, and other allied health professionals using Tetun to communicate. But there is an issue when you have to write in Portuguese. It means you have to process it 2 times. In our office, we produce documents in Tetun, and you have to translate it into Portuguese to get published in the government gazettes called Jornal da República. So there's a challenge in language, but Tetun is there to help. So I think the short answer is Tetun. Yes, Tetun is there.
One last question, thank you.
Thank you. Thank you very much for your talk and for the wonderful work you're doing. Well over 60 years ago now, one of our esteemed members who passed away only a couple of weeks ago undertook the same sort of challenge you are in Papua New Guinea. His daughter is granddaughter here with us today. I'm just wondering, have you looked at some of the challenges that sort of employed in Papua New Guinea, whether that's a good example or not, I don't know, but are there any learnings that you can, for the very similar sort of countries and challenges that seem to be the same from what Roy Scragg's late memory used to talk to us about? Do you ever see any similarities or any learnings from countries like that?
Thank you very much. We try to look for, I think in our program at the bank, there's a link with PNG too, but also current program at St. John of God, there is a link to PNG programs, and we learn a lot from that. There's some similarities in infrastructure. They are ahead of us. But one thing that is clear is that we're sharing the same difficulties. For example, internet connection. I think we're having the same problem as PNG, but also other countries in Solomon Island as well. I went to Rwanda. They share the same similarities. We have the same program called Connecting Mothers. It's difficult. We learn from Rwanda. We also learn from other African countries. And Indonesia is still one country that we still learn, because we tend to emulate what Indonesia has done. But what we try to do is not to repeat the mistake Indonesia has done in the past 24 years, but also look for our region. And definitely, PNG is one of our St. John of God area work there, even though it's limited service to mental health program, but we share a lot of information. We look around and look and see what we can learn from the past success and mistakes.
Thank you very much, Lourenco. That's a great presentation. And please join with me in thanking the florists.
Thank you.